Balancing the risks and benefits of dual platelet inhibition. Definition: an antiplatelet drug is a member of a class of pharmaceuticals that decrease platelet aggregation and inhibits thrombus formation.
Platelet adhesion and aggregation. In flowing blood, red cells predominate in the axial stream, while the biconvex disc-shaped platelets are marginated along the vessel wall, where they are well positioned to monitor the integrity of the endothelium. The normal endothelium provides a non-adhesive surface to circulating platelets. However, when vessel wall injury occurs, for example by cutting or severing of a vessel, or as shown here by a puncture, and there is endothelial damage, the initial response of platelets is that of adhesion to collagen fibers in the exposed subendothelium. Collagen is one of the most thrombogenic components of the subendothelial matrix, responsible for the initiation of platelet adhesion. A number of adhesive receptors on the platelet surface membrane interact either directly or indirectly with collagen. Initial binding of platelets is considered to occur via the integrin alpha-2 beta-1 GP1A2A receptor, which allows for further binding to collagen via the GP6 receptor, initiating transmembrane and subsequently intracellular signaling. Adhesion of platelets to the exposed subendothelium is influenced by shear rates. At high shear, alpha-2 beta-1 and GP6 are not sufficient to initiate binding to collagen, and binding of the GP1B95 receptor to von Willebrand factor, abbreviated here as VWF, that is immobilized on collagen, becomes essential in platelet adhesion. Platelet adhesion at the site of vessel wall damage initiates activation events that result in aggregation. Adherent platelets undergo a dramatic shape change to an irregular sphere with multiple filipodia spreading on the subendothelium, increasing their area of surface contact. Adherent platelets also secrete or release the contents of their storage granules, the alpha, and dense granules by an exocytic process. This provides a high local concentration of effector molecules essential for platelet plug formation at the site of vascular injury. For example, the aggregating agent ADP is released from the dense granules. Platelet activation stimulates the formation of another aggregating agent, thromboxane A2, abbreviated here as TXA2, via the arachidonic acid cascade. Details are shown in figure 26.5. The most potent platelet aggregating agent, thrombin, shown here as factor 2A, is formed via the coagulation pathway from prothrombin, or factor 2, on the procoagulant surface of the activated platelet. Details are shown in figure 26.6. ADP, thromboxane A2, and thrombin bind to specific platelet membrane receptors and stimulate aggregation on and around the platelets adherent to the subendothelium via receptor-mediated signal transduction events. Aggregation is an active metabolic process. Binding of any of the agonists to their respective membrane receptors initiates signaling pathways that ultimately convert integrin alpha-2b beta-3 or GP2b3A from a low-affinity resting state to a high-affinity activated state for binding extracellular soluble ligands such as plasma fibrinogen and von Willebrand factor. Fibrinogen is shown here. The transmission of an intracellular signal leads to disruption of the complex between the cytoplasmic tails of alpha-2b beta-3, followed by a conformational change in its extracellular.
Application in medicine. They are widely used in primary and secondary prevention of thrombotic, cerebrovascular, or cardiovascular disease.
Damage to cells and tissues, for whatever reason, results in nociceptive pain, inflammation, and possibly fever due to the release of chemical mediators known as prostaglandins by the affected tissues. These prostaglandins are produced by two forms of cyclooxygenase enzymes, known as COX-1 and COX-2, from precursor molecules known as arachidonic acid. The prostaglandins produced by COX-1 are generally responsible for the maintenance and protection of the gastrointestinal tract, kidneys, and other organs, while those produced from COX-2 are predominantly related to inflammation and pain responses. The prostaglandins that are released stimulate nearby nerve endings, resulting in pain signals being transmitted to the brain via the spine. Like other NSAIDs, aspirin mainly works by inhibiting the production of prostaglandins from the COX enzymes. However, aspirin does this by irreversibly modifying the COX enzymes, rather than just competitively blocking their action. As the production of prostaglandins diminishes, the intensity of the pain signals being sent to the brain diminishes. As the COX enzymes have been irreversibly modified by the aspirin molecules and can no longer function, the cells of the body need to make new copies of the enzymes, which may take a few hours. However, platelets do not produce new proteins, so their clotting function is impaired until completely new platelets are formed and replace the altered ones, which can take many days. Thus, while aspirin has a short-lasting analgesic effect, its effect on blood clotting can be relatively long-lasting.
So to continue straight on from the video explaining thrombogenesis and platelet aggregation, you'll remember I said activated platelets will produce thromboxane A2, and they do this via the cyclooxygenase enzyme. So aspirin inhibits this cyclooxygenase enzyme, thus decreasing the amount of thromboxane A2 production and thereby decreasing blood flow and increasing platelet aggregation. Now, clopidogrel and ticlopidine, on the other hand, inhibit ADP binding to a platelet receptor. So again, remembering back to the first video, I said platelets upon activation release ADP, which activate the same platelets via their own receptor, so this is autoregulation. And this is the site where clopidogrel and ticlopidine will act. They do this by irreversibly blocking this receptor. Now, you've also got your GP2B3A antagonists. These work here. Remember, the platelets upregulate this receptor, which binds to fibrinogen, which attracts further receptors on other platelets, causing platelet plug. Now, drugs that work here include the apixaban, a monoclonal antibody, eptifibatide, and tiofiban. These are all GP2B3A receptor antagonists. These are probably the most commonly used antiplatelet drugs.
The pros and cons. The pros: the addition of clopidogrel in dual antiplatelet therapy, a platelet P2Y12 receptor antagonist produces even greater secondary prevention of coronary events in high-risk patients for up to 1 year. And the cons. The drug toxicity may be increased when multiple antiplatelet drugs are used. Gastrointestinal bleeding is a common adverse event seen in many patients.
Hey, this is Yogesh Reddy from AHA 2014. I'm here with Dr. Mori, who was the PI for the DAP trial, and she's going to give us the scoop on this trial. Dr. Mori, if you don't mind telling us, what were the aims and design of the trial?
Sure. Well, the study was designed in order to see how patients with coronary stents should be treated beyond 1 year, especially because we knew that there's some risk of stent thrombosis and, more importantly, a risk of recurrent myocardial infarction in the late future.
And what were the results of the trial? What did you find?
So we enrolled 26,000 patients worldwide, and we randomized patients both with drug-eluting stents and bare metal stents to either continued thienopyridine plus aspirin versus aspirin alone. And the drugs that could have been used were clopidogrel or prasugrel, and there were multiple different stent types, including 50% of the stents, drug-eluting stents, were everolimus-eluting stents, so modern-day stents, so very relevant to current practice. And what we found was that in the patients who continued thienopyridine beyond 1 year, out to 30 months, that there was a very significant reduction in stent thrombosis, but more importantly in myocardial infarction. So the rate of myocardial infarction was cut in half, and stent thrombosis was reduced to 1/3 of what it would have been without that in the patients that were on placebo.
So, we have a lot of trials now telling us about the data with 6 months, 12 months, and now this trial with extended follow-up with 30 months. So which patients do you think, for the fellows in training, who needs to be treated for 6 months, who needs to be treated for 12, and who needs to be treated for longer?
Mm-hmm. Yeah, so, there is a lot of information about both these drugs and stents over the long term. There are patients that couldn't be enrolled in our trial because they had either had a heart attack during the first 12 months, after their stent procedure, and then they needed to restart the clock and take dual antiplatelet therapy, or others who had major bleeding and we didn't feel comfortable randomizing into the trial. So those sorts of patients, I think, you see how they're doing, and if they can't take it because they've had major problems with the drug, then obviously they're out. So, but what we found was that in those patients who hadn't had major bleeding or a major event within the first year, that even though there is a bleeding risk that's ongoing, that's probably counterbalanced by the benefits, because the benefits were so profound. It's a 2% absolute percentage point reduction in MI just over 18 months. And so that's even stronger than many of our secondary prevention trials, looking at statins and other things. So I think that this is just a new way of looking at secondary prevention.
Thank you so much. So for further videos from AHA 2014, please log on to youtube.com/FitsOnTheGo.
Issue applied inequality. Inequality dual platelet is used in a myocardial infarction after putting a coronary stent and prevention of secondary post-infarction.
Every year, millions of patients worldwide receive coronary artery stents for the treatment of ischemic heart disease. To prevent stent thrombosis after treatment with a drug-eluting stent, dual antiplatelet therapy with a platelet P2Y12 receptor inhibitor plus aspirin is recommended for 6 months to 1 year. The risks and benefits of treatment beyond 1 year have remained uncertain. The recently completed DAPT study randomized 10,000 patients who had received an FDA-approved drug-eluting stent, had already completed 1 year of treatment with dual antiplatelet therapy without having ischemic events, repeat revascularizations, or major bleeding, and had shown a high degree of compliance with that year of therapy. The patients were randomized to receive an additional 18 months of either continued dual antiplatelet therapy with aspirin plus a thienopyridine, either clopidogrel or prasugrel, or with aspirin alone. The co-primary endpoints were the incidence of stent thrombosis and a composite of death, MI, or stroke. As compared with aspirin alone, dual antiplatelet therapy resulted in a 1% absolute risk reduction, a 71% relative risk reduction in in-stent thrombosis, and a 1.6% absolute risk reduction, a 29% relative risk reduction in major adverse cardiac and cerebrovascular events. The rate of moderate or severe bleeding was higher in the dual antiplatelet group. At the 33-month follow-up, all-cause mortality was 2.3% in the thienopyridine arm, as compared with 1.8% in the placebo arm. This appeared to be driven by a higher rate of non-cardiovascular death that was accounted for by differences in major trauma associated with bleeding and in cancer-related death. The central conclusions of the DAPT study were that dual antiplatelet therapy continued for an additional 18 months, reduced the risk of in-stent thrombosis and major adverse cardiac and cerebrovascular events, increased the risk of moderate or severe bleeding, and increased non-cardiovascular mortality. While it doesn't offer an easy answer, this much-awaited trial adds important data to inform individualized decisions about the optimal duration of dual antiplatelet therapy for patients with drug-eluting coronary stents.
So, in conclusion, the use of aspirin can prevent and can be used in the risk of cardiac ischemic attack, but with the use of clopidogrel they can prevent easily instead of only using aspirin.